think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
So it seems like you've done some interventional radiography in your day.
Yep, I did. Yeah, I did. Yeah, it's all part of that neuroradiology training. You know, it's hard. I mean, I couldn't do it. You know, I couldn't do it full time. I did my training, so it was good.
That's hard on you, though. I mean, you know, you've had a spinal cord injury yourself, so you know you've got you've lived for a long time with it, and that's you're just you're to do what you do. It's kind of an amazing feat.
Well, I like it. You know, I'm motivated to do it, so that's why I like to do it. Help. You know, my case took like 7 years of process, and you know, I've got nice training background, so I can help the veterans with their problems, and makes me feel good about what I'm doing, and you know, helping the next guy in line. And then also, you know, I do it independently. I get the testing. You know, I make sure that stuff's accurate, and the doctor who follows me is going to understand what I'm doing. But also at the same time, try and, you know, Hippocratic oath and try and cure medicine. So I get testing for esophagus, make sure that they have esophageal cancer. We get cardiac testing, and we do bladder testing, and do bowel. You know, I do a lot of testing to make sure patients aren't falling through the cracks for their disease processes, because I get to look at the case for, you know, several hours, whereas the clinic doctor only gets 10 minutes, so that, you know, I can get a chance to do a whole body analysis and try and help them medically along with the VA rating schedule. That's the way it should work. You know, the veteran should be at an advantage because he's having these DBQs and these examinations, because he's getting a full body analysis and more testing, right, helping him live longer and be healthier. So that's the way the process should work if you have good doctors doing it and they have, you know, the ability to look around the whole body and order tests if they need.
That's true. That's good. That is good. You know, veterans are living longer today, true as it is. You know, I mean, they've got these weight loss surgery and things like that, and they're getting healthier, and that's a good deal.
Yeah, knock out infections. Yeah, that's a good deal. That's the way it should look. Especially since a lot of stuff is brought up in service. What's that? What's that?
Unless you go on the near-death diet like I did. I had a failed gastric sleeve and just about left the world.
No, did you bleed or get infected?
No, I actually had a blowout. One of the staples blew out the stomach, and I had to have 2 more corrective surgeries. Yeah. So I spent majority of in the last year in the hospital.
Digestive juices are eaten inside. Oh man, how
it was ugly. I mean, I had to do what happened was I had surgery and I came home on day number 4. I started having stomach pain, and it got later on in the afternoon. It got really severe, so we went back to the emergency room and they done a couple of tests, and they finally went and done a upper GI or whatever it is, you know, where you drink. And they saw it, and then they threw me and rushed me to the OR and got it cleaned out. And then about 2 weeks later, they had another one. So it was a fun time.
Another blowout. Did you have any fever infection with that or not? No. Yes,
I did. I had I had fever infection. I was septic. I had all kind of fun stuff. But I ran into a very. Go ahead.
Well, the reason you got septic, audience, is because leaky bowel contents. So there's a lot of sort of not sterile stuff that's leaking out in there.
It's ugly. It's really ugly. But I did run across a very good infectious disease doctor. It really helped me. Yeah. And, he was really good at what he did, and I think he's the one that kind of saved my life. You know, surgeon was pretty good too. But, you know, so it was a rough time.
Well,
it was 125 pounds ago.
Oh, man. Well, that's always a joke in medicine, is you keep getting sicker and sicker. Eventually you're going to see an infectious disease doctor, you know, because that's what gets really complicated. So those ID doctors, they do 3 years of internal medicine, and then they do like 3 years of infectious disease. So they've got nice long period of time in training. They can save your life. Yeah.
Yeah. They do. They're good doctors. I tell you, it's a good thing I ran into this guy. So.
Yeah.
But
medicine.
Dr.
Medicine's a team. You like the radiologist. Yeah. Go ahead.
Mm-hmm. When do you recommend? When do you recommend a veteran to get an IMO? What stage of his claim do you recommend?
Well, I like it. Yeah, I like it. I like it before the. Well, I mean, right off the bat. Needing service. I do these cases now with patients in service. It's really nice because I get. Because they have that benefit before discharge now, so they're having the VA doctor see them while they're in service. So, if they have a medical discharge, that board sometimes is biased against the veteran, and if the VA doctor is biased against them, then by the time they're exited from service and they go to the VA, they've got two negative reports on the record already. So what I try and do is try and get my IMO, IME testing done while they're in service. And when they're in service, all that testing is for free, and we can get it all done. 6 months before the exit, I can get all that stuff done. When the VA doctor rolls in, he's already sees my IMO or my IME, and he's got to either disagree with me or agree with me. If he disagrees with me, then he's not being truthful. He's going to get himself in trouble for malpractice thing or something like that. So normally, if I do my work and it's well documented and rationale, then they'll agree with me. And then a lot of times, if they agree with me, then the medical board also we can make that a little bit more straightforward. So then, by the time you get to the VA for the rating, the medical board lines up with the VA doctor's evaluation, lines up my evaluation, and your rating goes through. I've had patients, I've got them 100% right out of service doing that kind of a process. So if you're out of service, then you have, it's nice to have an IMO or IME. That when I do my IMOs and IMEs, I actually will critique the doctor and say, Dr. Smith said this. I agree with Dr. Smith on these 3 points, and I disagree on these other 3 points, whatever. So I kind of referee the medical opinions, which most doctors don't do. But I know that if I don't do that, then there's no way that the rater, who's a non-doctor, has any idea to figure out who Dr. A is or who Dr. B is and which one, who agrees with who and who doesn't. Just the rater's confused by the whole thing. So I kind of it's actually helping the rater referee it. So then, anytime there's a decision, especially now under the new schedule, if we have, the new rating process, if we have a decision that's negative, you want to put in a supplemental claim, you have to have new evidence. And so on that new evidence, you can use an IMO, an IME, more testing, so that way you get a better chance of getting a better rating because you have really concrete new evidence coming in. And then, the board, the BVA will take new evidence too, so with the BVA we can get evidence in. So I think any next level step, you should get IMO, IME, and also any place you have a decision, any negative decision, you should think about an IMO, IME. I know I can't even do all those IMEs, IMOs I'm talking about for all the veterans, but I'm just saying that to be a professional workup, you should really have, a professional write-up to make sure that all the different aspects are considered.
About how many IMOs and IMEs have you done, Doctor?
Well, I've done, it depends how you count this stuff, right? So 20 years, I've done about 5,000 patients, So if each patient, they said the average patient has seven issues, so I've probably done like 35, 40,000 issues, something like that.
Oh, that's a lot.
I did a lot of them. Yeah, I did a lot of them. Yeah, I just knock them out. I did a lot of them. That's probably didn't count the ones I was with the paralyzed veterans. I was doing those site visits. Every 2 weeks, I was going on site to the big hospitals, and I was seeing, we had like 20 inpatients, and I was doing lots of exams and a lot of stuff that was not. So what we did is I'd evaluate the patients, read the X-rays, and the bedside, and talk to the nurses. Then we debrief with the director. So I covered a lot of issues with the director, just verbally, and written reports that weren't really back in that day. They weren't really IMOs, IMEs. They're more like issues in the hospital that were wrong that you could use to help the director understand why you need to put resources someplace. This guy lost his leg because the nursing care is not good or something like that. So I've got a lot of experience. I've been in these VA hospitals. I know what the pressures the doctors are under. I trained in the VA hospital for 3 years. I talked to all these directors. We debriefed with the chief of medicine and chief of spinal cord and the director, secretary of the VA back in the day. So, I understand the culture and I understand the forces that the hospitals are under, and I understand the doctor, budget. I understand all that stuff, but I don't use that as an excuse not to provide good care to the patients, and I don't use the excuse to make sure the patients get the testing they need for their DBQs and for their rating,
Well, that takes quite a bit. Go ahead, John.
You still travel a lot, Dr. Bash?
I travel some, I travel some. It travel's hard on me, and it slows me down because I can't, my files are displaced in places, and then, I can't work as efficiently. But I can be talked into traveling places. I'm not nothing's broken. My wrists and shoulders all work. I can get myself around. So, but I'm getting older, so it's getting harder. But still move.
Yeah.
It's nice if I have a couple of reasons.
Yeah,
I'm in California right now for summertime, but it's nice if a couple of patients. I've told people if they gather 3 or 4 patients, or so I can go someplace and see them all at the same time. Or sometimes I'll have a patient wants to pay me to travel in to be an expert witness at a BVA hearing or a DRO hearing or something like that. I guess they might get rid of the DRO hearings now with this new process. I don't know what they're going to do with hearings, but anyway, I've traveled in there and be an expert witness. And, doing exam, expert witness.
You probably have you probably have a lot more success at the BVA level, don't you, versus the DROs?
I don't know. The BVA knows me just from a social networking standpoint. The BVA, a lot of those judges know my work over 20 years, and a lot of them I've been there talking to them directly, face to face, over many years. So they know that I'm a straight shooter and that I try and do the best job I can. And a lot of them welcome me because they realize I read the file. They realize I have the facts straight. And, what do you think, Dr. Bash? And I'll tell them what I think. I'm almost like an advisor to them, But at the regional office level, it's more complicated because there's a lot more. Was there 65 offices or something? And I don't know how many DROs there are, but there's several hundred of them out there. So the DROs don't necessarily know me personally as well as the BVA judges do, so that has an impact. But those DROs are really like little judges. I mean, they think the same way. They know the law. They know their experience. A lot of those DROs are more experienced than a lot of those new BVA judges now, because they're new on the block. And the DROs know the history of the VA and how it's evolved over time and what the rating schedule's done. So, I think it's more about the person than it is necessarily the place that I'm at.
Yeah, it's true. Makes a lot of sense. It does. That is true. It's more about the person than anything else, because if they understand the working relationship you have with them, it's a trust factor and things like that too. That's good.
The DRO, the DRO has a lot of liberty to decide whether they want. Like I did a case. I was in Baltimore. They're going to sever a guy, and that's it. There, the DRO walks in. He has kidney disease, 100%. On dialysis, and they're going to sever him. The DRO goes, "You just wrote this letter, right? You're a doctor, right?" He says, "Yeah." I said, "Yep." He says, "Wait a second." Walks out of the room for a couple minutes, comes back and has the patient sign the form. Says, "I'm not going to sever him. I'm not even going to turn the computer. I'm not even going to turn the recorder on. Get out of here." So those DROs can do. They have a lot of power. They can decide whatever they want, which is like little judges. So that's good. But like I said, I don't have the DROs. Are the DROs going to stay around with this new process they have? I guess
probably.
They do the upper level review, right? Yeah.
Yeah,
it'll be that second level review.
It is an effective measure that they use with the DROs. I mean, personally, I think it.
Yeah, I like them.
If I've got a claim, I'm going to the BVA. I'm not going to mess around with the DRO.
Yeah.
So it just, it just costs a lot of time. I mean, how many DROs have you been to, Gerald?
Oh, I don't know, several. About 3, maybe 4.
Yeah.
And so far, it's all been for naught. I don't care what you show them, they got a problem with it.
Mm-hmm.
Same DRO, Gerald?
Different.
Go ahead, Dr. Bash.
Oh yeah, is that the same DRO or is it different DROs?
Yeah, these are different ones that I met with.
Yeah.
But I can, even with your IMO, I had problems with them. And then I had problems with Dr. Bartels. See, he's a Agent Orange specialist, and I think he's got 2 clinics now. One down in Texas and then one back east there somewhere. But they had problems. It didn't matter what I showed them, you know.
Yours is toxicity, right? Toxicity issue. And the VA just notoriously wants to not talk about toxicity because they don't want to open the pipeline for millions of veterans. You know, so we win them, but you know, my IMO is probably still cooking for you. But you know, it's a hard issue for the VA to want to grant those.
Well, yes, it is, but they have owned up to the use of BX modified, mustard agent, herbicides, and radiation, and I think there's a couple more in there. So now they admitted that. They just say,
mustard, right? We thought yours was mustard, right? Was that mustard or something? What was yours?
Mustard agent.
Yeah, right.
I think that's what
they admitted you're exposed to it, but now they don't want to admit to the nexus, right?
Yeah.
And I probably wrote a strong. I don't remember, but I probably wrote a strong letter about the nexus. I usually do.
Yes.
Now they want to split hairs. Now they want to split hairs and full body exposure.
Yeah. Yeah.
Right. So you got to try to see it wasn't exposed low dose, right? Something like that.
Well, if you were in field testing, that's classified as full body exposure. So they couldn't really get away from that. But it's still, they've kept it in the appeal stage. So I can't get them to render a decision. They keep remanding. And
you probably got a big retroactive award, right, Gerald?
It's
a big retroactive award.
If I live long enough,
Right. That's why they're trying to delay it. Right.
Yeah. Right. Mm-hmm. So it's going to add up to quite some money right now.
Yeah.
I kind of pictured as that.
Oh, go ahead.
I kind of pictured as that Tremors movie where the guy's got all explosives on his truck in that warehouse and all them monsters in there trying to eat that MREs out of his truck. He sets that truck off. And he runs by the building and tells everybody to run. This is going to be big. And they stop about 100 feet. And he said, "No, it's going to be bigger than that." They take off the
Right. Better go 300 feet.
Yeah. No.
But so my analogy is the pole vault. You know, the first 1 foot of the pole vault's easy. The last 20 feet is really almost impossible. You know.
Yeah.
Like the VA, first 10% is easy and 90%, 100% is possible.
Yeah, they give you that. They give you that 60-foot stick. They use this.
Right.
Wow, that's a good analogy. That's a good analogy. Yeah. You got to stick that stick in the hole in order to do it.
Yeah, they don't understand because they say, "Oh man, the first 10% was so easy. You know, then how come this last 10% is so hard?" You know, it's that 60-foot pole, right?
Yeah, it's a 60-foot pole in VA math.
Yeah.
And if you get 90% in order to get 100, you got to get more than 10% because the 10 after 90 is only 1%.
Exactly. Yeah, 50%. Says where you are. You might be 88 too, or 87.
Yeah.
Takes a long way to get there.
Yeah. So at least you have to have 10 tens at 90% to even get 100, or 11 tens. I mean.
Yeah. Yeah.
Yeah.
Yep. Yep.
Because it's I don't know who came up with this math, but it's not your mother's math. I didn't learn this in school either.
Yeah.
Well, you know, they got a good bonus.
Yep. Disappearing math.
Yeah.
But Dr. Baxter, you service connected yourself?
Yeah, I am.
You are, aren't you?
Spinal cord. I got hurt. Yep. Spinal cord. Like I said, my case took 7 years. You know, because I got hurt sports, and then I think the problem with me was that I was young, right? So I was like 27 years old, so they didn't want any part of giving me give me a spinal cord at work, because I'd be living like 33. They saw me living 33 years, you know. So they didn't want any part of granting that. Number one. Number two, I got hurt in med school, and then I went to the rehab, and then I popped out and started back in med school in my wheelchair. So they're like thinking, well, this guy's fit. Well, I wasn't very fit, but I was tenacious, you know. And so that was that also hurt me a little bit. But you know, I got through it. My doc had to write like 5 letters, you know. Oh my God! I had to go down to the BVA and talk to I was down there back in the day. The BVA building was open to the public, right? So I went down there Friday afternoon, and one of the raiders, I don't know, it must have been I don't know what his role was. He must have been like one of the decision team members, you know. He was like, "Who are you?" I said, "Doc." He goes, "You're a doc in a wheelchair." He goes, "You didn't just fall off an apple truck." I said, "No, I'm hurt. My case is here somewhere." So he pulled it off the shelf and decided in a couple of weeks. It'd probably still be on the shelf. I wouldn't go down there, you know. It's crazy.
When they give you a hard time with your medical doctor, do they listen? You know, did they give you a hard time over your own opinions and stuff? Because I know they got slapped for doing that once to a doctor.
Oh, I mean, with me as far as my opinions?
Dr. Pons, Dr. Pons, he was like a chiropractor, and he got like a Jeep wreck overseas, and they kept discounting his opinion, even though he's a medical doctor. And he finally won his claim.
I didn't write anything for my own claim because it would be like bias, you know. Although the VA actually can allow that because your expertise, but I had my own doctor write letters for me, you know. So I took 5 of his letters. But the VA over the years has said derogatory things about me, you know, at the BVA level and the admin side and chief of benefits, and so I think I have 3 or 4 letters of apology from these high level, you know, Board of Written Appeals. So, you know, so now that was when I first started. They were really kind of had an abuse response. So now they kind of, if they recognize me as an expert and, you know, don't try to degrade me based on a personal attack. We just talk about the facts of the record, you know, and the data, the medical data, and the medical opinions and the rationale. So it's more peaceful now than it was when I first started.
That's good. That is good. Question about what are the grades of a spinal cord injury as far as, you know, complete, incomplete, things like that?
Yeah, so those are interesting terms. Like, you know, when you think about complete, you might think about the cord being cut all the way across, right? But it's not really like that. The cord is called a cord because it's really strong. It's 10,000 fibers, like I said, go down through there. So the guy in Australia has about almost 2,000 spinal cords, and out of all those cords, only a couple of them actually are really what's called transected, you know. So most of the cords are still intact at some level, and it's the same thing with the brain. The faster you get it treated, decompressed, the more fibers you can save, and it functions better. So once you have some function, then, you know, complete. Sometimes if you have a bad stroke or blood clot or infection, sometimes you can cut off the blood supply of the cord, and the cord will die, and then you'll have what's called a complete injury, which means there's not much function. There's some accessory pathways, but not much function below the cord. And then the incompletes are the other category where you have some residual function below. And so that's part of it. That's kind of a general term. And then we're getting better with imaging. We're going to be able to use imaging and grade these things in a more sophisticated way based on, you know, area volume and signal changes. And that's going to make a difference in how we treat it. But then, so once you have this incomplete thing, then you have to go through the testing. That's where the DBQ concepts come in. It's not really on DBQ, but you do muscle strength testing and sensory testing and range of motion, and then you do vibration, position, maybe hot, cold, and get an idea of what's going on with the different extremities. And you get that radiculopathy and myelopathy, so you can get rated for some percent for your cord, and you can also get rated for some percent for your radiculopathy for each extremity, and you get rated for the bowel, bladder, loss of function, stuff like that. It all gets into that special monthly compensation schedule, right? So you can't use your legs.
That makes a lot
Bowel,
easier.
bladder.
Okay, so I mean,
Yeah.
but spinal, I mean, it could affect every system in your body, every muscle too, couldn't it?
Yep. Yeah, it affects the immune system, it affects the bowel, it affects your bones, your osteoporosis, skin. Really, it's really complicated. You get out of control blood pressure, high and low, autonomic dysreflexia stuff. You can die from that. You can die from hypo or hyperthermia. You can die from blood loss because you can't compensate for your blood loss. And then complicating that, a lot of times you're throwing these meds at the patients. You're throwing these pain pills at the patients so their brains are obtunded and they fall asleep on the heater and burn themselves, or they'll get too cold and freeze to death, or they'll get infected and not feel it, and not understand why their blood pressure is going through the ceiling. And for spinal cord guys all those guys and all the neurologic guys, if their brain's not working well, then they can't protect themselves. Multiple sclerosis, all those guys are in big trouble. Car wreck because you can't drive. Get run over in a wheelchair.
Do you still drive? Do you still drive?
I'm still driving. I still drive. I'm starting to get away from that too. My family doesn't want to ride with me. I don't want to ride with you. You're not driving that well. I'll go across town. It takes 5 minutes this direction, and I'll take all right-hand turns. It takes me 10 minutes because I don't want to go make left-hand turns. Left-hand turns are dangerous. You got to cross the highway, or I'll take a road that doesn't have any speed bumps on because I don't want to rattle my spine around speed. It's crazy. Thank you all for listening. That ends this show, and now I'm going to zoom off.